Sir, please start. Thank you.
Good evening, everyone. Good evening, everyone. I'm Dr. Shailaja. I'll be presenting a short case for today. 5-month-old female child, first by birth, taken by birth order, born of non-consanguineous marriage, resident of Kandivli, hailing from UP, Hindu by religion with informant being mother who is a reliable source of information, brought with chief complaints of fever since 1 week, one episode of bluish discoloration of lips, limbs and nose for last 20 minutes. Fever. Hello.
ये मैसेजेस बंद कीजिए, आवाज बंद कीजिए।
Hello. Sorry for the interruption. Fever was documented 100 degree Fahrenheit, intermittent, not associated with rash or chills, relieving on medications. There was no history of diurnal variation of fever. Child was active in interfebrile period. One episode of bluish discoloration of palms, lips, nails, and sole, which relieved on its own. At that time, documented saturation was around 40%. On inquiry, child has history of increased work of breathing since birth in form of increased rate and depth of respiration. There is history of lethargy present, history of forehead sweating present, history of suck rest suck cycle present, history of weight loss present, no history of cough or cold, no history of recurrent LRTIs, no history of crying before the event, no history of bottle feeding, no history of decreased oral intake, no history of decreased urine output, no history of convulsions or excessive crying before the event, no history of COX or COX contact. Past history, history of hospital admission at the age of 3.5 months for 22 days, told to have pneumonia. At that time, some investigations were done. Documented weight was 2.3 kgs. Mother was told that child had some heart condition which will require intervention and was discharged on some oral medications. ANC wise, the pregnancy was registered, supplements were taken, ANC scans were done, which was told to be normal. There was no history of fever with rash or GDM or gestational hypertension or thyroid disorder in mother. Birth was full term LSCS. Child was told to be small for gestational age or IUGR. Child did not cry immediately after birth. Birth weight was 1.73 kgs. There is history of NICU stay for 33 days. Child required respiratory support in form of mechanical ventilation, which was eventually tapered, and the child was discharged as per mother. Child was investigated for congenital heart disease. Mother was told that the child has some heart condition and which will require surgical intervention. And child was discharged on some oral medications from the NICU only. After discharge from NICU, child was apparently alright at home and was feeding well. Child is immunized till 10 weeks. Developmentally, gross motor, there is no head control. Social smile is present. Fixing and following is present. Startle is present. Child was exclusively breastfed till 2.5 months of age. After that, child was started on formula feeds as per mother. Formula feeds as the mother has decreased milk output. From 4 months of age, child was started on cow's milk via Vati spoon feed. Family history wise, father is 32 years old and mother is 26 years old. They have an elder child who is 6 year old, female child. There was history of spontaneous abortion in mother at which happened in the first trimester at 1 month of pregnancy, and now this child is 5 months of old. 5 months old.
So, how will you start thinking when you get this history of 5-month-old baby with fever for 1 week? Forget about all the past history. This is your presenting complaint. So fever for 1 week and one episode of bluish discoloration. So how will your thoughts go? So one thought is about the fever, but just now maybe we'll focus on the bluish discoloration because fever we keep discussing many times. So what will be your thoughts on bluish discoloration in this setting?
Bluish discoloration may be pointing towards some heart condition.
Why heart condition? If I have fever for 1 week and bluish discoloration, it's a pneumonia who's getting bad. Why should I think of heart?
There is no history of cough cold also.
So more than cough cold, you have to ask for history of breathlessness, right? So basically, now can this be a breath holding spell? So what I want you to understand is you are saying one episode of bluish discoloration. So it is not just heart and lung. It could be even a seizure. It could be even a breath holding spell. So you need so many details of what that episode was and when did it happen. So can you tell us that? That is the first thing. What was the baby doing when that thing happened and how and the exact details of that episode?
Child was having fever on the day of presentation. Mother gave the medication to the child for the fever medication, after which she fed the child. Child was awake for some time, and after which the child suddenly started crying for some time, and after that crying was relieved by mother, but which was followed by bluish discoloration of lips and
Very good. So now this is important. So now that you have given this history, now you tell us, is this a breath holding spell?
could be a breath holding spell, because if there is history of crying present before the event, but age is not, the child is just 5 months old, the age for breath holding is not fitting.
So age for breath holding spell is how much?
Older child like it.
So 6 months textbook wise, but it can always be little earlier. That doesn't prevent anybody, right? So some other thoughts on whether this is a breath holding spell. What do you think?
Here is presenting complaint is with fever. So it can be a respiratory component which is triggering heart condition also and child.
No, agreed. Respiratory and heart are possible. We will come to that later. She just told us the history that mother fed the baby, then the baby was crying, and the mother somehow pacified the baby. Crying stopped, but then mother noticed baby is blue. This is the sequence she has given us. So now in this sequence, tell me, is it breath holding spell? Why not? Why are you so confident? You're right.
Because mother was able to pacify the child. In breath holding spell, the child will not persistently cry, continue crying for a very long time. And
But that's not the important thing, whether you are able to pacify or not. What exact
Cyanosis is present at height of crying.
and when does it disappear?
After
When crying stops, that cyanosis disappears because breath is restored. So that is what you have to pick up. So this 101% not a breath holding spell. Okay. Now, is it a seizure? I just brought it up earlier that it could be a seizure. Do you think this is a seizure? So in other words, how do you pick up a baby who has become blue, and how do you pick up that that episode was a seizure?
sir, seizure will be associated with other components like eye movement.
Need not be. No, this is a neonate or an infant. In infant, seizures are not necessarily very typical. Means you could have some features. So tell me subtle features of a seizure in this age group, which when associated with that bluishness would have told you, oh, this is a seizure.
Jitteriness.
Okay, jitteriness, something better. So the crying wouldn't have stopped. So unexplained continued crying. Then what else? Okay, forget this. Tell me, how do infants present with seizures? Do they come with tonic-clonic seizures? So what do they come with as seizures? Apnea. So apnea may not be, mother may not notice, but that's exactly what causes cyanosis. What else? How does a neonate or infant come with seizure? Staring look. Fantastic. Very good. Come ahead. Come here. Come from there here so that we can interact much more. So staring look. Then very good. So lip smacking. Then so some focal motor movement. So eye twitching, lip smacking, just some fingers twitching like this. So that's the peculiarity of seizures in very young babies. And why does this happen? Because they are still to be well myelinated. So the spread of the seizure takes a little time, right? Okay. Then we come to cardiac and respiratory.
Just one more point that when such a small infant has a proper seizure, the mother notices some different behavior. May not be able to explain what it means, but she said he suddenly looked different. So sudden change would mean that there was a transient loss of sensation, and then the child comes back again. But I'll give you one more possibility of sudden episode of bluishness, which got better by itself. Could it be methemoglobinemia, which is triggered by something, and the child does not have a very high level of methemoglobin, but just enough to get a small episode of cyanosis and then gets better by itself also. So methemoglobinemia with not so high methemoglobin concentration would exactly present that. So we do not consider that. So far, we have no idea about heart disease. And in the next slide, I think you had mentioned that it settled down by itself. But what was funny was you said that oxygen saturation was 40%. So did it happen in the hospital?
Actually, mother has pulse oximeter at home, so he used it on the baby because there's
So
discoloration.
that itself means that the mother has been told to have this because the child was subjected to it, right? And therefore, that itself gives you an idea that why did some doctor give her that? Average person, even a highly educated, doesn't keep them. And therefore, had it been a methemoglobinemia, it could have just required some trigger. And what are the triggers for methemoglobinemia? So that we would have asked what triggers what chemicals you get exposed to.
Carbon monoxide, okay, but something which is common, which you, what do children eat and then come with methemoglobinemia? So those preservative pills, which are there in clothes and in many other things, right? Naphthalene balls and all those things.
At this age, the child is unlikely to. But suppose in a cupboard with clothes, people keep some chemicals to prevent any cockroaches or whatever. So they may get used, they may get exposed to it. But this is just to bring to your notice that every time bluish is not respiratory or cardiac, but it could be hematological as well. Okay, and that keep in mind. It's certainly not common, but I recall having seen a neonate who on day 3 suddenly became blue and then suddenly got well. And they said, fine, God knows what happened, go home. And that child, during that period of anoxia, hypoxia, did develop some brain damage and came at 5, 6 months of age for a delayed development. And that history, that there was one episode, meant that that was a self-limiting cyanotic episode with normal birth history, which means that something triggered and one did the methemoglobin and it was about 7-8%, not too much to cause a persistent cyanosis. So I think just keep that in mind. Otherwise, it's sad. But why should it's cyanotic heart, right? But cyanotic heart should present like this on crying, on fever and crying. So do you need a trigger of fever or a trigger of crying for cyanosis to be evident?
So there will be 2 points to discuss. One is what sir is asking, that that crying really make the cyanosis evident? And then I'm going to tell you, but why cardiac? This baby had a lot of problems in the newborn period, was kept for 33 days in NICU. You are saying breathless since a long time. So this is respiratory. Why cardiac? So first answer sir's question, then second is this question. So does crying help to unmask a cardiac cyanosis? That is what sir is asking. Or there's no relation of crying to cyanosis. So let's go backwards. Which heart diseases cause cyanosis? I'm not asking the name, I'm asking the concept.
Right to left shunt.
Right to left shunt. Now, what happens when a baby cries?
When a baby cries, systemic vascular resistance increases and decreases, and venous return increases, so that shunting also increases to the left side of the hand. That is why which results in increase in sinus.
So, systemic vascular resistance decreases. So, the shunting is always a balance between systemic and pulmonary vascular resistances. So, if systemic has decreased, more blood will be shunted to the systemic side, less blood will go to the pulmonary side. So, less blood will get oxygenated. So, the cyanosis will deepen. Now, at your original point, this shunt was balanced. That means there was not greatly less blood flow in the pulmonary circuit. Then you will not see clinical cyanosis. And when this change happens after crying, that's the time that cyanosis shows. So you understood the link of crying to cyanosis?
So, pulmonary right ventricular input, there is a large volume coming in. So that further helps to have a right to left side. But then my next question is, at what level of oxygen saturation you see visibly obliteration? What oxygen? 95, 90, 85, 80? This was 40, so that 40 is too much. You have a mic. Give it.
Around 75 to 80.
85, 85. So till it goes down to 85 and below, you will not even detect cyanosis even if you are a doctor. So the mother would notice it only when it has gone further down and you have given some 40 years of it.
Now, come to my question, that this baby has increased work of breathing since birth or since a long time, and there's some neonatal issues also. So, how will you decide that this cyanosis is respiratory or cardiac?
There should be history of associated symptoms like cough, cold should be there to point it out towards the respiratory cause.
Ulta. You've seen many cough colds. Have you seen any one of them being cyanosed? So cough cold has nothing to do with cyanosis. Okay. So now think of the age, 5 months. We are saying breathless for a long time. So think of which 5 months old will be breathless for a long time due to a respiratory condition, and how does their cyanosis come in? So do you think 5-month-old will be breathless for a long time due to a foreign body? No. Correct? Right. So now think which reasons they can be breathless for a long time.
BPD and CLD. BPD and CLD.
Very good. So BPD, bronchopulmonary dysplasia, and interstitial lung disease, chronic lung disease. So now tell me what will be the story of such babies when they become cynos. What will they tell you? The cyanosis is very gradual in onset, okay? And then once it comes, it stays. It doesn't go away. You don't get episodic cyanosis, right? And that breathlessness is slowly worsening over a period of time, right? And as against that, you have to also ask for your cardiac history. That means difficulty in feeding and all that, right? Which supports your cardiac history. Okay.
Of a respiratory problem coming like this as a risk factor to begin with. So you had a premature, you had a lot of oxygen given, something that set up a chronic interstitial lung disease, or you may be born with some metabolic disorder which is causing an interstitial lung disease. So it would have started almost at birth. Depending on how severe it is, it could be later. But the cardiac problem never starts at. It takes at least 10, 12 hours or 24 hours before the first symptom. But till then, the fecal circulation is on. And unless the fecal circulation stops gradually turning to an other side, then only you start getting suffers. So cardiac fellows present on day 1, day 2, respiratory fellows present on day 1, if the problem is almost still there. So the cough may be still a possible symptom in a respiratory problem, but unlikely that is in a cardiac. Tachypnea would be there, but that one may not be respiratory distress. Whereas typically a cardiac breathlessness is a comfortable breath, which means it's comfortable tachypnea. Okay, whereas the respiratory breathlessness is uncomfortable. And why is that so? Because when respiratory problem comes with breathlessness, large part of the bronchial system or lungs are involved, like severe airway or severe interstitial lung, but not a pneumonia. And therefore, that is a small difference. So this is will prove otherwise cardiac. Okay. And you said right to left. So it must be an Eisenmenger as well. Most common is VSD, PDA, whatever. So left to right, and then mark pulmonary hypertension. So right to left. Okay. And balance for a while. Would you agree it's an Eisenmenger?
History and presentation wise, it looks like Eisenmengerization, but for Eisenmengerization to present at 5 months of age, which matlab, child had to had a heart disease since birth, and Eisenmengerization to happen at this age, it's too fast.
So why, on what basis did you say that history-wise it looks like Eisenmengerization? Means, so in other words, this sentence, what we are trying to say is, history-wise, it looks like first there was left to right shunt, then now it has become right to left. Does the history look like that? Let's dissect and decide. You tell us, does this history look like that originally there was a left to right shunt?
There was no cyanosis at birth, no reported by doctors. So it
Correct.
has to be a cyanotic. If any heart disease has to be present at birth, it has to be a cyanotic heart disease, which has now converted to cyanosis appearing on crying.
No.
It will take time to develop a pulmonary hypertension to present like Eisenmengerization. 5 months of age, it will take more time to develop pulmonary hypertension.
No, time depends on the degree of shunting. So if I agree that it will take more time, but what is more important when you are asked this question is, has it left to right has become right to left? You have to ask yourself, does the first part of the history look like a left to right shunt or no? So now these are your symptoms and we will kind of dissect that. So your symptoms are history of lethargy, history of forehead sweating, suck cycle. So all that fits in with a left to right shunt. So now first tell us details of this and then tell us whether you think this was left to right or it was not that. Then I'll come to your point that cyanosis should be present at birth. We'll explain that. So how will you confirm that this looks like left to right shunt? Confirm means on history.
Prominent symptom of a left to right shunt. Prominent symptom.
Pulmonary vasculation, blood flow is increased, pulmonary plethora is there, which
The
Symptom.
commonest symptom
Symptom, sir, is asking.
the patient come with. He comes with cough. And when does it start? It takes 2-3 months to start. Why is that? VSD is there since birth only. And it's the large VSD, which is presenting very early.
They will be including the supply to the systemic circulation. When the PDA starts using the
No, that is in duct dependent lesions. That's a separate thing we are talking of. Sir is asking that PDA is there right at birth. Why does it take a little time for that shunt to become well established and then come with symptoms? It's not PDA.
flow keeps on increasing and overload will result in presenting the child with pulmonary overload, say child will
Dominant, but after some time, the left side becomes dominant. Right, and therefore, most of them will start as the pulmonary circuit starts coming down. As he said, right-sided dominance starts becoming left-sided dominance, and which takes few weeks really. And therefore, typical VSD starts at 6 weeks, 8 weeks time, or 2 or 3 months time, even if it is large, and starts with what? The cough. And therefore, the presenting symptom is cough. Then if you don't attend to it, he gets into cardiac failure, suppressor, etc. Breathlessness. So this child possibly did not have that kind of a story, and therefore we would say this is not Eisenmenger. In fact, Eisenmengerization, I don't remember whether I've seen in the last 30, 40 years. Maybe when I was training 60 years back, when the cardiac surgery had not come up, people would, at 10 years, 8, 10, 12 years of age, children would come with Eisenmengerization. But not otherwise. Today, nobody should see Eisenmengerization and don't discuss. Because everybody is treated well right before all that happens, right? And therefore, this is a cyanotic heart to begin with only. Then why did he not present so early? It's not like VSD, whether it depends on the right-sided dominance to become less. Okay.
chronic overload and the right side of the heart would result in developing pulmonary hypertension and right ventricular.
See, Dr. Chokani always talks about 3 types of cyanotic heart. Have you heard him talk in that? You start with that.
So whenever you look at any such infant with what looks like a cyanotic heart disease, in your mind, you have to answer 2 questions. First question, you have to always tick the box, what we just discussed. Was it originally acyanotic, which has become cyanotic? And we just discussed that this is not the case here. So then it is originally cyanotic. Originally, cyanotic, you divide them into two groups physiology-wise. What are the two groups? So we just discussed why does the baby get cyanosis? You told me some reason, no, why the baby gets cyanosis in a congenital cyanotic heart disease. What reason you said? Before that, right to left shunt, right? So when you said right to left shunt means what? Less blood is going to the pulmonary circuit. That's why baby is getting cyanosis. Can there be any other way that less blood is going to the pulmonary circuit? Can there be a block? There can be a block, no? So to understand, divide cyanotic heart disease into two groups. One group is with less blood flow to the pulmonary circuit. And the second one is normal or increased blood flow, but still cyanosis. We'll understand what is that second group. Understood first, less blood flow to the pulmonary circuit. So cyanotic heart disease is divided into cyanotic heart disease with reduced pulmonary blood flow and second with normal or increased pulmonary blood flow. Okay. First, take the reduced group. In reduced group, there are two possibilities. One is there is a obstruction. Example, pulmonary stenosis. Again, we have to discuss that. So is pulmonary stenosis itself a cyanotic heart disease? Pulmonary valve stenosis is not a cyanotic heart disease. It is a acyanotic heart disease. So pulmonary atresia is an obstruction where no blood goes. And there you all were talking of PDA supplying, and when PDA closes, it's a critical thing. The baby collapses and it's a death, life and death situation. But what is the commonest cyanotic which you all see? Where there's obstruction to the pulmonary blood flow. Top, Fallows. So that is your example of reduced pulmonary blood flow due to obstruction. Okay. The second group is increased pulmonary blood flow. In increased pulmonary blood flow, though there is increased pulmonary blood flow, there's still cyanosis. Why is this happening? Because of two reasons. One is parallel circulation. Example, TGA. So there is a lot of pulmonary blood flow. Systemic is going to pulmonary, but there is no connection only between the two circulations. So that is rotating like this is rotating like this. So the baby is cyanosed. Correct? So that is increased blood flow, but still cyanosis. And the other one is increased blood flow, but actual mixing of oxygenated and deoxygenated blood in the same place. So that gives you cyanosis. Example of this, TAPVC single ventricle. Understood the groups perfectly. Now please go home and read this today. You will never forget this. So these are the three groups. Reduced pulmonary blood flow, Fallows. Increased pulmonary blood flow with parallel circulation, TGA. And increased pulmonary blood flow with mixing of blood, single ventricle, TAPVC, etc. Now look at the clinical presentation. So when will Fallows present at birth? At birth, you've seen Fallows at birth? No. When does it come? 2, 3 months, 3, 4 months, even later. So slowly it comes up, right? So that is classical of Fallows, that the cyanosis is slow in onset, progressive after a few months, 2, 3 months, 4 months, whatever. Okay. When does TGA come up? Parallel circulation. At birth. So deep cyanosis at birth, your diagnosis is TGA. Okay. And now that third group, where there is mixing. So one, because there is increased pulmonary blood flow, the clinical symptom signs are that of what you see in a VSD typically, right? So you see all these failure symptoms, breathlessness and suck cycle and all that. And because there is mixing of oxygenated and deoxygenated blood, you see cyanosis. Now, will this cyanosis be mild or deep? Think and tell me. You have oxygenated blood also, you have deoxygenated blood also. Mild, fantastic. So, failure plus mild cyanosis is this group. Deep cyanosis is parallel circulation group. And slowly coming up cyanosis is Fallow's group. Understood?
The point that we made is, in fallows, there is an infundibular action, not valvular. And it takes time for the cyanosis therefore to come. The point is, even when there is a mixing, but if the pulmonary obstruction does not exist, then in spite of that also, the
My key fell down.
mild enough. And after all, when there is a mixing, the nature sees that oxygenated blood gets a prominent part of that mix. And therefore, the cyanosis is mild. So finally now, the presentation depends on two things: type of reason for cyanosis, but also important is how good or bad the pulmonary circuit. If the pulmonary circuit is fairly good, for example, there is a mixing, but enough blood is going, then the cyanosis could be mild enough and maybe noticed a little late. Otherwise, there would be mild cyanosis but noticed early. So two things decide: one, reason for cyanosis, and another is pulmonary circuit, how much it is obstructed. Then think about the anomalous pulmonary venous stent. If there is no big obstruction, then possibly, if there is no obstruction, then if there is no obstruction, then the presentation would come a little later. And if it's a partial anomalous pulmonary venous drainage, then it might even take some more time. And typically, therefore, a TAPVC presents almost like an acute bronchiolitis. And you miss it. And a partial anomalous pulmonary venous drainage is often missed as an AST, unless you are very particular to pick up a mild cyanosis. And can you guess, because there is no visually blue color, but can you still guess that there could be cyanosis? And the reason is, commonly CBC is done. Can CBC guide you that there could be cyanosis, but I can't see it? So if a 3-month-old child, what should be a normal hemoglobin of a 3-month-old? He starts with 16, 17. How much down he comes up to? 10, 11. And if at 3 months he's 15, you say, no, he is very good in hemoglobin. No, you start wondering why is hemoglobin. So there could be a hypoxia which is hiding. So keep a note of all that.
So now in this baby, we discuss these three groups of cyanosis, cyanotic heart. Tell me which one is it? Which one are you expecting in this baby? Fellows, it has come up at 4-5 months of age. Agreed, fellows? Agreed or no? What is not fitting into fellows? Okay, it's not yet progressive. It will progress with time. But what is there in this baby which is not there in fallows? Failure. So this baby has symptoms of failure which suggests increased pulmonary blood flow. And we said fallows is decreased pulmonary blood flow, right? So this is not likely to be fallows by that logic. Now someone may argue that could it be fallows with lot of collaterals? So then what is your thought process? If fallows has a lot of collaterals, then they can go in failure. But then what will not happen? Where are those collaterals going? They are taking blood where? To what? Lungs. If they are taking lot of blood to lungs, then what will not happen? Cyanosis will be delayed. Correct? So fallows with collateral should not have too much cyanosis or should come up late. So these are the thought processes. Now can this be TGA? No. So what is it best fitting into as of this stage? Now don't say TAPVC. There are many conditions there, but mixing. So the group where there is increased pulmonary blood flow and actual mixing. That's the group which is fitting best because there is mild cyanosis which got triggered on crying only and there are symptoms of failure. Now we'll see what comes as later as findings. Come.
On arrival to the ward, child was febrile with heart rate of 170 per minute, RR of 80 per minute. Subcostal retractions and intercostal retractions were present. SpO2 on room air was 89% in both upper limbs and 70% in both lower limbs. Peripheral pulses were moderately felt, central pulses were well felt. Extremities were cold up to ankle and wrists. CRT was less than 3 seconds and HGT was 126. On head-to-toe examination, child was sick looking. AF was open 1.5 centimeter by 1.5 centimeter, non-bulging. Head, neck, face, spine, abdomen were normal. Loose skin was present and cyanosis was present on lips and limbs. Anthro-wise, the weight of the child was 2.1 kg, which comes to less than 3 standard deviation. Length of the child was 49 centimeter, which again comes to less than 3 standard deviation. Head circumference of the child was 36 centimeter, which is again less than third standard deviation, and weight per length was less than 3 standard deviation. So impression is failure to thrive.
How do you, no, okay, so anyway, now since you have put up this, interpret one by one everything. Just make it a habit to interpret everything. Heart rate 170, 5-month-old, normal, marked tachycardia. So sir is saying this is a rhythm disturbance, could be a paroxysmal atrial tachycardia, supraventricular tachycardia. What's your answer to that? Yeah, but first of all, we must know the demarcation between the limits of sinus tachycardia and a rhythm disturbance. 220, 220 in an infant and 180 in a child. Okay, so that's the limit to differentiate between sinus tachycardia and a rhythm. This is sinus tachycardia. For what is the reason, we'll see. Then respiratory rate 80. What does that tell you? So marked tachypnea, right? Now, what about the subcostal retractions and intercostal retractions? What do they tell you? Are being used, but pathology wise, where is the problem in the lung? Very good. Intercostal for parenchyma, subcostal for lower airways. Okay, try to use specific words. So airways. So that means there is expiratory airway obstruction as well as parenchymal problem. Okay. Now we'll discuss some other time, but this is a classic situation in pulmonary edema where you get both these components. Then SpO2 she has given 89, 89, 70, 70. Then peripheral pulse, extremities cold. What does that mean?
Pulses were also moderately felt, peripheral pulses, and extremities are cold. So circulation might be hampered for a brief period of cyanosis.
Yeah. So peripheries cold is to be taken as a sign of poor perfusion, which is to be taken as a sign of shock, but you have to correlate with everything else and decide whether this is, what are the two types of shock? Compensated and hypotensive. Now we don't use the word decompensated, we use the word hypotensive. So compensated or hypotensive. So that you decide based, but that's the meaning of extremities cold. Then go to the next. Fever could have aggravated, absolutely. Peripheral vasoconstriction. Next slide. Okay, now tell me the interpretation of the anthropometry. Interpretation. Baby was born 1 point.
1.7 kg.
So 1.7 kg has become 2.1 kg at 5 months of age. So there is less than -3 SD and all that we know. But what will you make out of this? Why has this happened? Do you think it's only due to the heart disease?
Could be due to faulty feeding also.
So there has to be a dual reason for such severe failure to thrive. Okay. So it's a incomplete nutrition plus, of course, the catabolic state of persistent cardiac failure. Then will we call it microcephaly?
Microcephaly.
Yeah. So what is the other anthropometry to be studied in the first year? Length and head.
Diane's form.
Conference by Diane's formula. It's length by.
Okay. So this is within fitting in with the length of the baby.
Systemic examination. Previous inspection wise, the precordial bulge was present. Apex impulse present in left fifth intercostal space lateral to mid clavicular line. No visible scars, dilated veins or sinuses. On palpation, all inspectory findings were confirmed or palpation. Apex beat was present in left fifth intercostal space lateral to the mid clavicular line. Palpable left parasternal heave was present. On inspection, precordial bulge is present, which point towards increased heart size, like cardiomegaly or increased activity of the heart. So, chronic, which has led to hypertrophy, and that is what causing precordial bulge. So, apex impulse looks slightly displaced, like if it is going left to the in midclavicular line. So, it is pointing towards ventricular hypertrophy. Enlargement. Speed same as apex impulse also. And palpable left parasternal heave. So parasternal is the location for right ventricle. So could be pointing towards right ventricular hypertrophy or enlargement. Percussion could not be done. Child was small. No auscultation. S1, S2 were heard. There was pansystolic murmur, which was better heard in parasternal region. There was no radiation of the murmur. And CNS wise, the child was hypotonic. Reflexes were normal, and power was greater than 3/5 in all four limbs. RS wise, air entry was bilaterally equal and clear. On abdominal examinations, abdomen was soft and non-tender, but there was hepatomegaly of 1 centimeter, but liver span was 6 centimeters. Spleen was not palpable. Impression. 5-month-old female child, second by birth order, born of non-consanguineous marriage, brought with complaints of fever since 1 week and 1 episode of bluish discoloration of body with history of past admission for LRTI with suspected congenital heart disease. Immunized till death. FTT by anthro is probably a case of congenital heart disease. I would like to keep my differentials for could be a large VSD or patent ductus arteriosus or pulmonary stenosis. Uh, Small VSDs do not come with any episode of stenosis. So if there is mixing of blood happening, it has to be a large VSD, which is making right ventricle and left ventricle as single chamber, and there is increased history of cyanosis on crying also, which is again pointing towards mixing, which is getting activated. So and
We are not discussing small VSD at all. That we agree. The question is when you give a DD of a large VSD, that means your VSD is what shunt? So you are saying that this whole disease is a left to right shunt. In which case you have to explain that cyanosis. So why did that cyanosis occur if it is a left to right shunt?
primarily when I was thinking, I thought it is a primary left to right shunt which has gone into Eisenmengerization, and that is why I kept my differentials like this.
After our discussion, like we said, we will not keep that Eisenmengerization as a possibility, and therefore we will not give any DD which is originally a acyanotic condition. We can't give that DD, right? So therefore, large VSD is out. Even PDA, is it originally cyanotic or acyanotic? PDA. Originally, is it cyanotic heart disease or acyanotic heart disease? Acyanotic. And what about pulmonary stenosis? We just discussed. Pulmonary stenosis can be a 10-year-old, 12-year-old with just a harsh murmur and nothing. So it is not a cyanotic heart disease, right? You need to have a way for that blood to go the other way. Then only you can get cyanosis. So therefore, that's not. So probably at this stage in the exam also, you could say what we discussed earlier, that this is likely to be a congenital cyanotic heart disease of the variety where there is a mixing of blood in some chamber, which is why this child has come with failure, cardiac failure, and mild cyanosis, right? Differentiating between all those causes may not be possible clinically. Okay, like single ventricle, TAPVC, double outlet, all that we can't possibly differentiate.
Sir, between a large VSD and simple ventricle, the large VSD could act like a simple ventricle.
Theoretically, you are right, but basically both it all, as we said, it depends on the pressure gradients of the systemic and the pulmonary. So as long as the systemic resistance is higher, the the shunt will be left to right. Correct? This pressure is higher, this is smaller. So the shunt will be from left to right. So that is when you will call it a VSD. But in a single ventricle, there will be no pressure gradient only. Right? So it's like one chamber with two large vessels.
Investigations. So total bilirubin was 0.6, OTPT was 47 and 20, ALP was 136, total protein 5.4 with albumin level of 3.8, RFT is 99.5, CRP is 1.9. On ABG examination, 7 point pH of 7.441 with PO2 of 24, uh, sorry, PCO2 of 24, PO2 of 94.8, and bicarb of 17. And serum electrolytes were 140 and 4.02. CBC of the child showed HB of 14.0 with hematocrit of 35. WBC counts were 16.9, which was granular predominant, and platelet count was 231. Arterial blood gas and so sorry. So, to present with child had tachypnea. So, PCO2 level is 24. So, there is PCO2 washout on ABG, but oxygen is 94%. So, PO2 is 94, which is near normal limit. But this ABG was taken on NIV. So, child had O2 support at this point of time. It was not taken when the child presented.
Is 7.44 normal?
Slightly alkalotic pH.
With the definition of alkalosis.
pH greater than 7.45.
44 is normal. So first understand that. See, even if in those SDs, you always make that mistake. -2 SD means you think it's abnormal. Up to -2 SD is normal. So 7.45 tuck, it is normal. 7.44 is below that. So this is normal. If you are asked in the exam, interpret this ABG, what would you say? This ABG shows a pH of 7.44, which is just within the normal range. It is at the alkalotic end. Why is that happening? Because of the respiratory washout. So CO2 washout. And the compensation by the bicarb is preventing it from actually becoming alkalotic. Correct?
We did a 2D echo for the child. Provisionally, it is suggestive of large perimembranous PSD of 7 mm with bidirectional flow, 3 mm PDA with bidirectional flow, and 2 mm OS ASD with left to right shunt. There was severe TR and severe PH and normal biventricular function. Child was advised after a final 2D echo report, child has been advised for intracardiac repair. Currently, he has been referred to cardiac.
Okay, so now go backwards and explain your physical signs. No, the cardiac signs.
Precordial bulge, again pointing towards enlargement of heart, and this palpable left parasternal heave is pointing again towards the murmur which was present. Murmur could be due to right ventricular hypertrophy,
Which is due to?
pulmonary artery hypertension.
Very good. Which is due to severe pulmonary artery hypertension. So ideally, what should you have got here? Another sign. A loud S2.
Yes, sir. Loud P2 also.
Loud P2,
P2.
loud S2. Yeah. But why did you not get it?
Tachycardia was so
Exactly,
much.
yeah.
because I
So
couldn't
nobody will make
differentiate.
out in that much tachycardia. So you're right. But we would have got that as a sign of pulmonary hypertension. So the right ventricle is due to that. Why is the left ventricle enlarged? Come on,
Chronic.
simple, no? Why is the left ventricle enlarged?
How decompensation is happening.
You have three, you shown us three lesions, all of them left to right shunts. You told us there's a VSD, there's a PDA, there is a ASD. All of them are left to right shunts. So there is a huge left to right shunting happening. That is why the left ventricle is enlarged, no?
This is a complex heart disease, therefore it is presenting. In the exam, you will never call it the left to right shunt. And because you knew the final diagnosis, you are putting your three things. I'm afraid in an examination, if a candidate for a cyanotic heart says left to right, I would almost fail that. And I'm serious about it. How can you just say that? Okay. Even if you are shown there after this, you would say, I would not have suspected this at all. I think then you would get a medal also. So don't go by that. I think your presentation depends on what you know already and you are trying to fit in there. The story would never fit in. Now imagine multiple malformations. That happens. And therefore, for heart defect, you need an echo today, and even echo might miss something. But we are not able to pick up a complex heart disease. Just because you got some signs of VSD doesn't mean that it's a left to right shunt with VSD. So I think this is an example which is so rare, and in an examination, because it is rare and a supervisor has told you, you will fail. Because the examiner wants to know how you argue your case, not what comes out finally. Okay. If he wants to know what comes out finally, he will only ask you what is the echo finding. Why does he bother you all this? So take a note of this. And because you knew it, you put three, and he clearly said, I would not have thought of any one of them. Now it's rarely all three are there. I don't know when I saw last all three. Okay, but that's not because this is actually proved. The question is that when look at the story very, very clearly. The story would have been certainly a flop. Story should have been certainly that first 1 month or so things were all right. And this is an important of taking a good history. Otherwise, you would feel what looks like a cyanotic heart could be Eisenmenger's at 5 months away. No, it doesn't happen. So this child must have had in the first 1 month or something suggestive of a left to right shunt. Okay. And that would have been picked up by our strong reasons we discussed that first some part of the story, the child never had any suggestion of a cardiac problem. That means even the tachypnea came up a little later. But this child being 1.7, in spite of a full term, so this child had many reasons to be not normal right at birth, and therefore could have had a tachypnea at birth. Okay. But on detailed questioning, if the child was further discharged, the child was kept in the hospital for a long time. So the point that I'm making is don't remember this child and every such child of cyanotic heart you call it, have seen once this. You've never seen one like that. Okay. And therefore, give a diagnosis. What is the moral of the story? Don't ask the supervisor, and if he tells, don't give that diagnosis. And even if your diagnosis is wrong, you will pass because you have justified. It's like a court. Okay, you have to convince the judge that what you are saying is right. And I think that is important. So good that it was a good case, but I could see your putting it was pre-knowledge that this is one of those. Okay. And I think you must ask your cardiac specialist whether they have seen Eisenmengerization of disease. Answer would be no. Then you would say that. So I would even start asking my echocardiologist, are you sure this was a left to right to begin with? Or there is something else wrong? I would go to that extent because it extremely rare. I would also ask my cardiologist friend whether how often they have seen it. But what I'm trying to say is that we don't certainly refute the echo findings, but we want to tell the echocardiologist that this looks very rare and are we missing something else on an echo? Okay, because echo also needs an interpretation by a person. And to that extent, we should sound them.
So I think what you all learn from this case is that approach to a cyanotic child, that thought process that we discussed. Okay. Next case.
So this child must have been sick, right? So, but otherwise, it's a good to get the child because in this case, we would have asked the parents again the history. And it's not rare that while taking history, one might miss, right? And therefore, this is not, but as often as possible, bring the child also so that we could convince ourselves about the finding as well as sometimes the history. And I remember earlier days, I'm talking about 20 years ago, in this hall only, the child would be there, and before we started, one of us would look at the history and findings as well, so that we would question what is presented. Okay, because otherwise we start feeling that we are learning something that we never thought of, which may not be right always.
Uh, 4-year-old, 4-year, 3-month-old boy, second by birth order, born out of non-consanguineous marriage, hailing from UP and residing at Govandi, Mumbai, Muslim by religion, Baloch by community, brought by and informed by mother, with complaint of frequent falls since yesterday and double vision since yesterday. Child was apparently all right till yesterday 8 p.m. when he was playing, started complaint of giddiness followed by complaint of double vision and loss of balance following fall. Child was able to get up on his own but unable to balance and had multiple episodes of fall. Mother made him lie down and made him to rest for 2-3 hours. Child continued complaint of double vision and for which mother took him to private practitioner who referred her to higher center. There is history of fever 2 weeks back. No complaint of headache, loss of consciousness or convulsion. No complaint of confusion or altered sensorium. No complaint of decreased limb movements. No complaint of photophobia or diminution of vision. No history of any drug intake. No history of prior trauma. No history of loose stool or abdominal pain. There is no history of loss of smell sensation. No history of facial numbness or difficulty in chewing. No history of hearing difficulty. No history of difficulty in swallowing or hoarseness of voice. No history of difficulty during turning head. No history of no history of deviation of tongue or feeding difficulty. No history of recent vaccination. No past history of similar complaints. Mother was on antidepressant, stopped 6 months back. Past history, had history of fall from height at 1.5 year of age, approximately from 2 feet height, no loss of consciousness or bleeding from nose, ear, or no history of any convulsion at that time. CT brain was done, told to be normal. Documents not available right now. ENC history, conception at the 22 years of age, registered. ENC scans were done, told to be normal. Supplements were taken. TD injection was taken by mother. No ANC complications. Birth history, full-term normal vaginal delivery. Birth weight was 3.5 kg. Baby cried immediately after birth. No NICU stay or no neonatal jaundice. Discharge on day of life 2. Immunization till date. Developmentally appropriate for age. Uh, Diet history, there is a calorie deficit of 250 kilocalorie and no protein deficit. Family history, there is a broken family. The father lives apart from mother from last 2 years. Mother has a 6-year-old male child, and this child is 4 year 3 months. Social history. Mother studied till 12th standard, security guard by occupation, earns 14K per month. lower middle class according to modified Kupus-Common scale. Impression.
So what are your thoughts on the chief complaint? He was playing and suddenly complained of giddiness followed by double vision and loss of balance, and after that he fell. So first analyze this first line, what are your thoughts? Then the second line and so on.
Can be syncopal.
Okay, can be syncopal attack. Now let's take it further. So what all, or describe a classical syncopal attack, and then we'll see what is there in this and what is missing in this.
Associated multiple falls.
Okay, so multiple falls is out, but even let's take the first one. Let's take the first fall.
Since history of giddiness is there, so it points towards syncope. Giddiness is there, like episode is preceded by giddiness. Can
So what is a typical translation of giddiness in vernacular language? What does the patient tell us?
check
Chakkar. What does chakkar mean? I don't know. Tell me. You think it means vertigo, but what all it can mean? What I'm trying to say is this word chakkar or giddiness is very confusing and vague. So we need to be very clear of what the patient is feeling. So make it a habit that whenever anybody comes to you saying chakkar aata hai, you say, I don't know what is chakkar. You tell me, you describe what is happening to you. Okay. So fine, that is one. Now, you were saying that giddiness makes it syncope or doesn't make it syncope.
mostly makes it syncope.
So now, can you all collectively explain how does syncope start? No, symptoms.
Giddiness followed by blackout.
So one is the patient may feel black
Blackout.
vision or so a feeling that he is going to fall, he or she is going to fall. That is known as prodrome, which is a very important part of syncope. But you forgot the most important thing. What happens before that? Excellent. There has to be a trigger. So look for a trigger. If there is no trigger, then two things. Ask yourself. One, it's not a syncope. And two, if it is a syncope without a trigger, then you have to think of something abnormal. Right? Like a rhythm disturbance or cardiac or whatever. Right? Okay. Then, do syncope have double vision? Never complain of double vision, right? They just complain of that blackness and then they just lose posture, right? What else will you ask the passerbys or the people who are around to confirm that this was syncope? Backward, forward doesn't make a big difference, I suppose. What is the reactionary things done by the body What happened in syncope? They will try to hold fine. In syncope, why did they get syncope? What happened physiologically? Cerebral blood flow reduced because. So how does the body compensate? Sympathetic outflow, no. So what does the body do? Sympathetic outflow signs are more than that, sweating and blanching, peripheral vasoconstriction. So ask whether the patient became white or pale and whether they noticed any sweating, right? Then quickly the patient gets up. So that was one thought, whether this is syncope. We've discussed it's not. What else? Any other thoughts? Okay, could be a stroke, a vascular event. Very good. So now discuss that further. So what happens typically after somebody gets a stroke?
There'll be some kind of paralysis or loss of
So focal deficit. So after that, there should be a focal deficit, which here it is not, right? Okay. Okay, can be acute onset ataxia, right? So take that further.
Question leading to any sensory or cerebellar involvement like coordination impairment or any sensation loss.
It's difficult for the parents to judge whether sensation is lost, and what at the most you can get from history is whether this is a localized or a generalized problem, unilateral or bilateral, right? That much you can get from the history.
I think one point would have been important, that when he felt giddy, and did he fall down and got hurt or no? If he did not fall down and got hurt, that means he could prevent his fall. Okay. Now,
Able to stand on his
fine.
own.
And therefore, we have syncope is out. Okay. What about vertigo? Vertigo, the person will get a feeling and might go for a support. Did he do that? Okay. Vertigo fellows may not fall down, but they look for a support. Okay. And it rarely happens suddenly. So this child had never had an injury, which means he knew that he would fall. So when he knew he would fall, one of course could be vertigo, but that moment he supports, he would be all right. But if it was a balancing problem, he would have to probably sit down and not continue to stand, or would need a very strong support for him not to fall. Then you would have asked uh, that could he stand at that time? When you say loss of balance, okay, could he walk?
He was able to stand on his own, but couldn't walk.
Because
He had multiple falls at that time.
when it happened while playing, how did he come home? So, so who lifted him up? So all those details would have told us that he was fully conscious, but he probably lost. Then suppose that he was made to stand up. Could he walk at that time, or he refused to walk? That means his problem, in spite of fall and then recovering from fall, because of still not want to walk, which means the fall was due to something persisting there. And what is persisting there? Then some balance problem. So you have some suspicion of a cerebellar disorder. But does it cause a double vision? Then let's forget for a while imbalance and let's discuss double vision only. And then let's see whether we have some common thread to connect one another. So who will discuss the double vision? What is double vision really? It's a visual problem? Yes. Then why is it? Is it retinal?
So
Well,
let's start from basic. Why do we see normal, and when double vision happens, what is the problem that is happening in the eyes at the physiology level? What is the basic problem? I don't want any complex answer, just our understanding. What is double vision?
The image of both.
Perfect. Failure to superimpose both the eyes ka images. Perfect. When will this happen?
If there are any lesions which is pressing on the optic nerve,
Lesions will see at the eye level. When will this happen? When there is a squint. Okay. So if this has happened suddenly, then probably the question is that did he acutely develop a squint? And that's why he developed a double vision. And then that squint persisted. So he developed a double vision, right? So this is the problem at the eye level, right? Anything else? Ocular muscle weakness, okay. That would again lead to an imbalance or the lack of coordination between the two eyes, and it could cause a double vision or diplopia, right?
that means that there is an external ocular muscles are not all functioning. So why should happen suddenly? And why should it happen in both eyes? Check on all that. Is it both eyes or one eye? Is it at only one extreme or otherwise? Okay. Did the parents notice some squint? That will make looks like a squint when you said double vision. But we could go further on that. And then this has suddenly happened. So we need to ask whether this was seen earlier, that he had a little squint. Okay. Now that he has had some problem, it was noticed. Because suddenly developing squint due to some extraocular muscle weakness is not common. And therefore, you get typically a left lateral when there is a raised ICT. And that too, it doesn't come up suddenly. So we need to ask all those details. But it's good enough to say that there must have been a squint in this child, an acutely developing squint. Now, what could acutely develop? It can't be acutely developing increased intracranial tension. Okay. Then what it is? So is it a neuritis where my sixth nerve on one side is involved and I get a squint acutely? Okay. Even that is not common. But yes, any localized nerve lesion could come up. And therefore, if that is so, then why is the cerebellum involved? So how do you look at that? That is at third, fourth, sixth, pretty away from the cerebellum. Okay, it's right in the midbrain up there. So cerebellum would have been close to pons. So sixth, seventh would have been there. So would it be sixth involved because of a cerebellar involvement? Okay. And there could have been seventh also on examination. Then you get almost a cerebellopontine angle. Okay. So we need to look at all that. Because to me, acute onset is a vascular till proved otherwise. And if it's a vascular, then why does a cerebellar lesion present with 6 or 7 nerve palsy? Doesn't fit in unless there are two different areas of vascular obstruction, which is unusual. So again, we'll go back to history and say that was there some headache earlier? Would he be irritable? Would he be vomiting sometime? All that to make sure it's acute. But if it's acute, then two different lesions maybe, but that's unusual. One has seen moya coming with different
Sir,
lesions.
acute demyelination.
Yes, or but only selectively. looks too selective. And because sixth nerve and cerebellum are common, are close to each other, I would like to link that possibly. But this acute onset, I can't link together. Had it been a tumor, yes. So I would worry whether this was already pre-existing. And point is, let's go further on the cerebellar tumor. Okay. Suppose this tumor was small enough and therefore could have had a very minimal disturbance, minimal symptoms. Okay. And if that suddenly had some reason to be big, like some bleed there, okay, these are not usual at all. But I'm just trying to say is that a small asymptomatic tumor can suddenly increase in size and present as a symptom. So we will at the best say that there are two different lesions and therefore a common cause could be, as he said, demyelination, nerve involvement. And that's the best diagnosis that we can.
So just to complete that, after that first statement, in the history, how we would have taken a more perfect history is that, okay, suddenly he was playing, he said, Mala chakkar yete, then he saw double vision, then he lost his balance and he fell. Then you would ask the mother, then what happened? Then he, mother must obviously have picked him up. Nobody will allow him to get up on his own. They'll say, chal, chal, I'll pick you up. Then you say, then what happened? So I imagine when you are saying that unable to balance and had multiple falls means he got up and then again tried to walk and run and again fell and again tried to walk and run and again fell. Maybe this is the history, but this is the way you would have asked. Then if that is the history, it brings in the issue whether he became paralyzed and that's why he couldn't walk and fell. So then you have to confirm whether it was unilateral, bilateral, whether he was moving his legs and he was able to stand, as sir said, which means he was not paralyzed. Otherwise, they would say he was not able to stand only. So what I'm trying to say is that between power and balance, you can try and differentiate on the history, whether this was a power problem or a balance problem, right?
Impression: 4-year, 3-month-old boy born out of non-consanguineous marriage with complaint of acute onset frequent falls with diplopia, with history of fever 2 weeks back, in completely immunized and developmentally normal child, to rule out acute onset ataxia, cerebellar versus sensory.
Okay, now this happened. When did this happen? Means what happened after that in the next 2-3 days?
Diplopia persisted for 1 day, and fall were subsided when patient came to the hospital.
He came to the hospital on the second day.
Same day, but after coming to hospital, there were no falls, and diplopia persisted for 12 to 15 hours and subsided on its own.
And after that, he was able to walk
Yes.
without losing balance.
Yes,
So
yes.
it was a transient
Transient.
episode of loss of balance and all
Yes.
that.
Yes, yes.
So loss of balance, I am not very sure, but the rest could be even a vestibular migraine, which is rare, but there again you will get giddiness, diplopia, loss of balance, etc. for a few hours suddenly, and then the child is fine.
On examination, general condition fear, lying down on bed in supine position, febrile, heart rate was 120 per minute, pulse rate 24 per minute, saturation 98 percentage. Peripheral pulses and central pulses were well felt, extremities were warm. BP was 90/62, which is between 5 to 58 centile. Pallor present. Head to toe examination, no abnormality detected. Anthropometry, the weight is 12.6 kg, which is between -3 to -2 standard deviation. Height is 100 centimeter, -2 to -1 standard deviation. Head circumference 50 centimeter, -1 to 0 standard deviation. and mid-upper arm circumference 14 centimeter, -2 to -1 standard deviation. Weight for height -3 to -2 standard deviation. Impression is moderate acute malnutrition. Systemic examination. Central nervous system. Patient was conscious, oriented to time, place, person when arrived. Lying comfortably on bed in supine position. Cranial nerve examination. Uh,
All normal.
yes, sir.
Okay.
Motor, normal muscle bulk, no wasting or contracture. Detecting no any chronic malnutrition or disorder related to CNS. Tone was normal in all four limbs. Power more than 3/5 in all four limbs. Reflexes, superficial, conjunctival, and abdominal and cremastic reflexes were present and normal. Deep tendon reflexes were also normal. Plantar flexure, no clonus. Sensory, pain, touch, temperature, sensation present. Proprioception present. Romberg sign was negative. Cerebellum, dysdiadochokinesia present, normal. Finger nose, finger test was normal. Heel to toe test normal.
This diadochokinesia was present or it's not there?
Not normal.
It's normal.
Gait, broad based gait with tandem gait was present.
There is broad-based gait.
Huh.
Child has not come here.
No, sir. Per abdomen and rest of the systems were within normal limit. Impression, a 4-year, 3-month-old boy born out of non-consanguineous marriage with complaint of acute onset frequent falls with diplopia with history of fever 2 weeks back with broad-based gait with normal tone and reflexes with negative Romberg sign and in completely immunized and developmentally normal child, probably a case of acute cerebellar ataxia to rule out post-infectious or embolic vascular ataxia or drug intoxication.
So presently, the only signs that the child has is a broad-based gait.
That is also resolved, sir.
But when he came in, did you have
Yes.
signs of ataxia that time?
No. Falls were not there, but broad-based gait was there and diplopia was there, which was resolved after 12 hours on its own.
I think clinically it's a vascular lesion. The question is, where do you localize it? Obviously, it's a posterior circulation, okay, and not anterior circulation. So posterior circulation takes care of the cerebellum and around. So also probably pons. And therefore, one may consider that it just picked up some areas of cerebellum and around. Okay, it all depends on, like, for example, a hemiparesis we see commonly may not be a typical middle cerebral artery, internal capsule, dense hemiplegia. No, it could be many variations depending on which area are involved and which area are spared. I imagine the posterior circulation is also the same. So to me, it's a posterior circulation and quickly recovering. So almost a self recovery in a short time. So it must have been a vascular spasm only. Now, what he was talking about migraine is a vascular spasm. Okay. Now, he was considering also the 8, okay, year. So looks like something like a migraine as it suddenly happened and suddenly disappeared. Well, at this point of time, even if you do all investigation, nothing will be seen because the child has already improved. So we'll have to just guesswork what must have happened. Now, acute vascular lesion suddenly improving so quickly looks to be unlikely thrombosis, embolism, hemorrhage, etc., or vasculitis. It must be vascular spasm only. And to me, that is equivalent to migraine, for example, which happens in 24 hours, disappears completely. Might ask the parents whether there is a history of migraine. We might ask this child whether there has been some headaches. Okay, to substantiate the possibility of a migraine-like syndrome. I think that will be the best because, and the question is, how are you going to counsel this patient? Besides saying, of course, we are good doctors, we cured you in no time. But How will you counsel the patient? Give a thought. And what I mean is, parents are worried, will it happen again? And if it happens when the crossing the road or it's dangerous. So are you going to stop him from swimming and crossing the road and playing outside? What would be your way of putting it up? Give a thought, because we must learn also finally how to counsel, because surely this parent must have asked you, what happened? Of course, here what happens is parents don't ask much questions, we don't allow them to. We are in a hurry, they are also in a hurry. So they are happy or all right. Okay. But normally, even this parent must have asked you, कि फिर हो जाएगा क्या? Now, to which what did you answer? कुछ भी हो सकता है नहीं. So how would you just try to give it? So I'm asking you, how do you counsel when you don't know what the problem is and still need to be counseled?
Sir, family history-wise, there is a broken family. So, stress and psychiatry reference can be done for child if there is. So, child will not communicate that with the mother.
Did not communicate what? Okay. Okay. Anybody else wants to attempt counseling? You want to try? Just to make you revise, in counseling, basically what you have to tell the parents is what is the problem? Why is the problem? Is it life threatening? And how are you going to treat it? And what is the long term, if anything? Right? Broad outline you have to give. So how will you tell them?
Um, this problem could be due to a blood vessel, due to a blood supply issue, and as transiently, it was a transient problem, which means that there is a good chance that it could recur. Uh, Having said that, we should also know the trigger of why it happened, and we it would be better to for counseling with the child and the parent together to see what actually we feel is the trigger for such an episode.
I think all that you say is that what has happened to your child is like suddenly this lamp goes away and comes back again. The parents have seen this. So what has happened? The current suddenly did not reach there, and then it by itself came back again. So same thing has happened in your child, that some part of the brain did not get a blood supply, so current did not go, and it was nature did it again. So we have seen this happening in our house. You don't rush to call an electrician. And suppose you ask him why it happened. He says, we don't know why it happened, but this has happened for the first time. I will check, everything looks normal today. Okay. And the brain has developed well. Everything is all right. So we don't know why it happened. Okay. Now they understand that many times this happens in our house. The lights go off and lights come also. Okay. Now when the lights go off, we start looking at entire building has gone up, entire flat has gone up, only one room has gone up. That means focal. So here it has been a small part. Like in one room, one light went up. Now the question is, would it repeat again? You said theoretically yes. Okay. But I haven't seen many times this happening. Okay. Same thing you do there, no? You don't ask the electrician, would there be a short circuit? Would there be a fire? Yes, everything is possible. But you don't take an action. Why? Because you go by probability. And therefore, very likely this may never happen. But we want to further make sure whether there is anything that may happen again. So we want to ask about migraine, Okay, we like to see whether there is, obviously in this child there is no reason or risk factor of any thrombosis, embolism, etc. So we would say that let us believe today that it was just a bad luck, and luckily the nature has set it right. Now the question is, theoretically, yes, it could occur again. So we have no clue here, and we are not going to investigate, we'll not find anything. So what could you do? For some time, let him be protected from fall. And what does it mean? Let him play when somebody is around. Okay. Let him not cross the road on his own. Let him not go and swimming. Let him not jump from top. So we will have a protected life for a while, just to ensure that next 3 6 months nothing has happened. Then we would say that if long period has gone without anything, this light has never given me trouble last 3 4 months, I'm happy. I don't know what happened. And then I don't worry about it. But if it happens again next day, then I'm worried. So I would say for next 3 months, lead a protected life within limits. And if it doesn't happen, we have a reason to say mostly it will not happen. See, in counseling, you have to be very fair and honest. What I said is fair and honest. I did not want them to take a burden of stress. I've given them a confidence. At the same time, I've told them, oh, this may happen again. So I've told them, take protection for 3 months. If nothing has happened for 3 months, it's a good time. Nature seems to have decided not to give it again. I think this logic helps. Okay. And what we did is give confidence to the patient, take away their worry, still speak the truth, and give the right advice. Okay. If you call him again after a month, what will you say? So finally you say, anytime he feels again little of this, please come back again, because we have not seen him right at that time. We might know something better, right? Both the cases were quite interesting. Okay. And one was completely normal on examination. So that's a good challenge to say what must have happened.
Just one small thing on this nutritional thing. I think we see this too often. That's why we want you to understand this. So take one by one. What is the weight? 12.6 minus 3 to minus 2. What does it mean? First, just the interpretation of weight. Is it normal or abnormal? Abnormal. Okay. Minus 2 standard deviations corresponds to which centile? 95th is तो ऊपर ना. अभी ये सब है ना, वी हैव टू एकदम पक्का करना पड़ेगा. So minus 2 standard deviations corresponds to which centile? Fifth नहीं, third. And plus 2 standard deviation corresponds to 97. So 97 से third के बीच में there are 95 centiles. So that is how it becomes your 95% of the observations under the Gaussian curve and normal and all that, right? So you leave 1 and 2 here and you leave 98 and 99 there, correct? So now which is plus 3 centile? Plus 2 we said is 97. Plus 3 is 99. And minus 3 is first centile. This much is clear. Now, by definition, we define normal as third to 97th minus 2 to plus 2 is normal. Okay. Which means, what is the height of this child? Normal. Minus 2 to minus 1, but normal. What is the head circumference of this child? -120, but normal. What is the mid upper arm circumference of this child? Normal. And so therefore, this is one thing which we people are somehow making mistakes. The moment it comes minus, we think it is abnormal. So up to -2 is normal. So in this child, all this is normal. Now, how do you, I'm asking you, we are learning, so don't feel bad. How do you get this weight for height? What do you actually do? When you are calculating or you are finding out the weight for height, what do you do? You plot it on a chart, or what exactly do you do? Or you calculate, or what do you do?
Tables are also available. Wait for it.
There are tables available. So in that table, what is there?
Height is given, and on upper side, right side, there is a weight is given for that age by analysis.
So you try and see where the two meet. How do you know it's -2 to -3?
Weight is given according to standard deviation. The left side there is height, and upper column there is weight given according to standard deviation for that height.
So first you take the height, and then you look at the weight according to standard deviation. And then you say whether it is -2 to -3. So what I want you to understand is that this weight or height abnormal is important when your height is affected. If your height is normal, weight for height is bound to be low, no? Because you are low upon normal. Weight is low, weight is your numerator. Denominator is height. Height is normal. So low upon normal is going to be low. So that low does not have any other significance. It is low just because your numerator is low. You understand? So your starting point is that height is affected. So when you're talking of chronic malnutrition, we say wasted and stunted. And so when we say stunted means height is affected. Now height is already affected, and for that height weight is still lower. So that is your weight for height low, which puts you in that category. Am I clear on this? So the starting point is height affected. So if height is only not affected, then there's no point in this whole exercise. Got the point? So don't make this. And please remember, up to -2 is normal, -2 is normal. Keep saying this 100 times because it doesn't strike us that up to -2 is normal.
I think at best the child may have lost a kilo or two, or otherwise he would have been just small in weight by stature. And several people are little less in weight but normal in height or even good in height. So when you say ma'am or whatever, you start looking at height first. And if height is normal, it's not nutritional. Okay. Acute years. Okay. I was sick for 4 days. I've lost 2 kilos weight. So weight will go down, but not height. In this child, height is normal. So this is not nutritional problem at all. And therefore, ma'am or Sam is out. And I think he explained it so well and clearly. Because he brought out rightly, because in many Thursday sessions, ma'am has come. Okay. And therefore, ma'am looks to be a common finding at the end of the test, but it is not. In an exam, this is the way you will argue. All right?
Online audience, any comments, any questions, anything?
Was a MRI done for the second child?
No, not done.
And that's it. Thank you so much.
Okay. Thank you everyone for joining in, and we meet once again next Thursday.
Thank
Thank
you, Dr. Amdekar, Rajesh, and all the children who have presented. It was wonderful. Thank you.
thank you.